Hello, I'm Ziad Ghazal with CVN, and we're interviewing today Dr. Sanjid Jolly from Hamilton, Canada. Finally, Sanjid, a very large randomized trial, over 7,000 patients, comparing people treated either with angioplasty or just going for cardiac catheterization, and randomized to radial versus femoral, the rival studies. So tell us about the design first of this trial.
Okay, so this was a large, simple trial, and we included patients with both non-ST elevation, acute coronary syndrome, and ST elevation myocardial infarction, who were undergoing an invasive approach. And patients had to have an intact dual circulation of the hand, and the interventionalists had to be trained in both and willing to do either for that particular patient. We randomized patients in a one-to-one fashion, and as you mentioned, we randomized over 7,000 patients in 32 countries worldwide. And our primary outcome was a net benefit composite. It included death, myocardial infarction, stroke, and major bleeding. And what we had observed in prior trials is that there appeared to be this link between major bleeding and mortality as recurrent ischemic events. So the hypothesis of the trial was that if we can reduce major bleeding, maybe it'll have a greater effect and reduce mortality and other events.
And what did the trial show?
The trial showed that the results were not different. So the rates were 3.7 versus 4%, 3.7 for radial, 4% for femoral, which was not statistically significantly different. But what the trial did show is that PCI success rates, which I think is was an important question, were identical in the two groups, and that we saw about a 60% reduction in major vascular complications. So I think those are important findings. The second very interesting finding that we had was that in 2 of the 6 pre-specified subgroups, we saw a benefit. Those at high volume radial centers, the upper tertile, there was a benefit for the primary outcome as well as multiple secondary outcomes. And in patients with ST elevation MI, we saw a benefit for the primary outcome as well as other secondary outcomes, including mortality for radial.
But you did show that the radial approach consumes more radiation.
Yes. So
what do you make of that, especially now that there is a bit more concern about this radiation?
I think it's a very important question. Radiation is an important occupational hazard for interventional cardiologists. So I think there's 2 points. First, we did show about a 1.3 minute increase with fluoroscopy time with radial versus femoral. When we stratified the results by operator volume, this difference was markedly different. It was markedly attenuated in those high volume radial operators, high volume centers. So in other words, this difference probably the gap narrows once you get more experience.
Very good.
And I think the third option is it's important to realize that fluoroscopy time is actually not such a good measure of overall radiation dose.
Exactly.
And we do have a radiation sub-study with regards to air kerma dose area product that we're working on the data right now and we'll follow.
Good. Thank you very much, Dr. Jolly, for joining us.